Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Esa Davis from the University of Maryland School of Medicine about connecting back to care, reimagining maternal health. Let's get started.
Dr. Dan, hello, sir. How are you?
I'm good. How are you, Faisel?
Great to see you. I'm doing great. And we're so excited we've got you over here, Dr. Davis. Thank you so much for joining us today.
Yeah, thank you for having me. Good to see you both.
You know, when Dr. Dan told me about you giving grand rounds over at UVA, it reminded me of a conversation I had when I finished residency. So I made the choice to move to Hillsborough County from Columbus, Georgia, because Hillsborough County at the time had some of the worst maternal mortality rates in the country. But what he ended up being my boss, but what the CEO told me of the FQHC was the main reason that the maternal mortality rates were so high was just from lack of someone to just put a hand on a belly. It was very, like, that struck me. I couldn't believe, being first generation American, that, gosh, in America of all. And then I get into the space, and when I got into the space, yes, that's one big piece of it, was not having hands to put on, but also where you live. And so when he told me about, hey, we heard this lecture, I was like, okay, we had your email, shoot you an email, and having you on, I can't tell you how excited we are to have you on today.
Well, thank you. Thank you. I'm very excited to be part of this really important conversation.
Well, at least with us, we're family doctors, passionate about talking about these things and getting the word out. But I'd love to know, especially for the students, most of our listeners are students, residents, early on in their career, people who are geeky about primary care, passionate about primary care.
Oh, that warms my heart.
Yeah, we're family doctors.
That warms my heart. That warms my heart.
So what led you to look at where people give birth as a key driver in maternal mortality?
You know, it's one of those things that follow the data, right? You get into, you hear a statistic and you hear, first of all, mommies are dying. You're like, wait, what? Right? And then you're like, is that true? Why is that? And so I looked at, what's going on in the United States, and then you see, well, this is really high here. Well, then what's the comparison? Then you look overseas to some of the other countries that are, similar, France, UK, and Canada, right, starting big. And you see that their maternal rates are drastically less. And then you say, well, what, right? We're supposed to be in the most wealthiest country, right? The country that has access and all of these things. How can we have, right, like almost twice the death rates? And so, it's just starting to kind of, right, start to think about those things and realize then each state, right, start to look at the states, and the states are different, right? So if you're, unfortunately in Maryland, our maternal death rate is 21 per 100,000. Right? The country's death rate is 19 per 100,000. And to put that in perspective, France, UK, and Canada is 8 to 9 per 100,000. Right? And so then you start to look at, well, why is that? And then you start to drill down even more. I'm now in Baltimore, and being in Baltimore and looking at what's happening here, particularly in West Baltimore, right? Our rates were even higher, right? And it all depends on, what community you live in and what kind of access that you have. And we can get into all of that. So, but, it starts with that, just hearing that statistic and then questioning it, right? Like, what? Why is that?
And then, as I recall, you have a personal story of why this interests you as well. And I know you've shared it before, so I think our listeners would probably like to hear about that as well.
Sure, absolutely. I do start usually my talks off by saying, I'm a researcher, I'm a family doc, right? I'm a national expert, all of the things. But I think my most important qualification and perspective on this particular topic is because I'm a mother myself. So I have 2 children, but with my oldest, I have a son. And I am very healthy. I didn't have any medical problems kind of going into pregnancy, and had a pretty uneventful pregnancy. But I delivered my firstborn at 40 weeks by C-section. And then within about 2 to 3 days after delivery, I developed heart failure. I couldn't breathe. I couldn't walk. I was really short of breath, right? Had all the signs and symptoms, couldn't lay flat, without feeling short of breath. I had edema, pitting edema, or swelling from my feet all the way to my waist. And I'm still in the hospital, right, at this time, right, 2 to 3 days after a C-section. And my husband, who at the time was a resident, he was a senior resident, and I'm a family physician. He was an internal medicine resident at the time. He kept looking at me. He said, "You look, you're in heart failure." And he wanted to be a cardiologist at the time, right? So we reported my symptoms that night. And, everyone that I would report them to, essentially were not impressed by my symptoms, right? They told me when they came in and took my blood pressure and it was 150/90, at the time they told me that was normal, and that my O2 sat, on the monitor of 94%, which, as you both know, for somebody that does not have lung disease, that is not normal on room air. But that really, my symptoms could be attributed to just being in pain, and so, we just need to manage our pain and all of these things. But then I was discharged the next day, and mostly what was supposed to happen the next day, that morning, day of discharge, someone was going to come back in, take my vitals and everything. But because they were more focused on the baby and the baby's weight was slightly down, which was normal because I chose to breastfeed. And so, my baby's weight goes down a little bit, but they wanted to just make sure that I followed up and all of that once I was discharged. So I didn't actually get my vitals rechecked before I left. And, it's busy, right? But it's really busy, right? But among that discharge planning process. So anyway, the day after discharge, it just so happened I was home. And then the next day I went to go see my family physician. And while I was there, he was focused on the baby and the weight check. But I said to him, I was like, can you just check my blood pressure? I just wasn't feeling well. I was like, can you just check my blood pressure? And so the nurse checked it. And I remember her face. I'm sitting there and she's checking it. And I looked at the little reading and it said 220/110. Like I could just see it, right? And she waited and she paused. I looked at her and I said, it's high, isn't it? And she said, I'll be right back. And so she goes flying out the room to get him, and he flies back in. And, and then I got an x-ray and my lungs were full of fluid. And so, of course, they sent me back to the hospital by EMS. And because I was returning to the hospital within 24 hours, I triggered all of the utilization alarms. And then I basically was in the hospital for another week. And during that whole time, it was really challenging to, kind of work with my medical team, right? And now I'm the best case scenario, right? I'm a physician, my husband's a physician, right, you would think that we would have, and we're educated, all of the things, right? But it still was really difficult. We had to try to negotiate on finding safe medications that would support. I had a desire to breastfeed, right? And there was, all this apprehension about, like I was being difficult because I was like, questioning medication. Is this safe? Can we do this? Right? I really want to breastfeed if I can, right? Or if I raise the need for, why do I need IV fluids since I'm like 7 pounds over, in fluid, right? And I'm able to drink. Do we really need IV fluids? But of course, I was labeled as a difficult patient. And it was, there were many moments where it was really just difficult, right, for people to listen, to partner in my care. And I actually relied on my lactation specialist, who was my greatest advocate and liaison with the medical team. And so, it's just, it was one where understanding both sides, being a physician, being in the busy setting, knowing how, the hospital is really busy and nurses are stressed and we're all right trying to just do what we can. But we forget that on the other end of that is a patient who this is their first time experiencing this, right? We may see things 1,000 times. We may know how they, right? But from my angle, right? And really just giving myself permission to be the patient. Right. I wasn't trying to be the doctor. I wasn't trying to manage my care. I wasn't trying to tell people what to do.
You were trusting everything.
I just wanted to be right. But I also was going to question things that I didn't feel were like, why are you waking the baby and me up at midnight to take to, wash the baby? Because you're setting us up for right? Because the baby's not going to get washed at midnight at home. Like, I understand why we do it, because this is the time where it's downtime. The nurses finally can catch up. They can finally, get the babies all washed up. But I'm like, but you wake us up and now what? Right? It's midnight, and right. It's like, so just, there are a lot of system things, right? System things that we do out of convenience for us. We don't think about, right, how it's going to affect that patient and how they're going, how we're setting them up when they go home, right? So anyway, I'll pause there.
Well, but when we hear about racial disparities in healthcare, but yet, does it really have anything to do with the color of your skin? I mean, if you look at people in Africa, are they having the same increased mortality between the races that we do in this country, or is there a huge difference when you come to the system that we have here?
That's a great question, and I would say the rates of mortality are high there too. I think that there are some differences though, right? Because in Africa, there are just some structural differences, and so other factors that they have to take in consideration that we, in the United States have, right? We have a really robust healthcare system. I mean, despite, some areas having little differences, but for the most part, right? You go to an academic institution, it's got all of the bells and whistles, right? It does. And so the thought is, if you get to, right, that place, and if everyone's getting the standard of care, right, you would like to think that there should be no differences by race. So I think one of the studies I shared was just as an example of standard of care and still seeing differences. So I have a colleague, we did a study where in this particular institution, remote blood pressure monitoring is the standard of care. So every patient who has a hypertensive disorder of pregnancy gets it rolled into the remote monitoring blood pressure program, and they get their blood pressure tracked for 6 weeks. And what we saw was that when you have that monitoring of blood pressure for Black and white women, the systolic, diastolic, and mean arterial blood pressure does fall over that amount of time, right? But and that's getting the same standard of care. But when you look, there's still a disparity between Black and white women. So Black women still have a higher systolic, diastolic, and mean arterial blood pressure, even though both curves are coming down. There's still a difference, right? So their blood pressure in that first 6 weeks after having hypertensive pregnancy is still higher. And then you have to ask why, right? Why is there that difference if we've given the same standard of care? So it's just an example that there are other things that might be playing into it, both, and not just all system level. There's also patient factors and also the, interactions that occur.
So much I want to talk with you about. I mean, that was the first time that you experienced symptoms when you were pregnant after delivering the baby, with feeling the difficulty with catching your breath and all. Was that like your first major? I had something like that too about 10 years ago with pneumonia. And I remember having that conversation with my wife, who is not a medical person, about the difficulty. I was like, I'm fine. I was ready to go to a clinic that morning. I was like, I'm fine. I just can't catch my breath. And she was like, you cannot catch your breath. You're experiencing what's called shortness of breath, doctor. And it wasn't until like my mother-in-law threatened to extend the paramedics to my home that I actually left. And I'm so grateful I did.
Yeah.
But if nobody chooses to be in these, I mean, you were going through a lot the baby and like being a mom and here being sick. And then on top of juggling all those things, you're dealing with the medical system, which is just crazy. I mean, I've heard the worst stories from doctors and nurses. I don't know. Like, I feel like we have like something with us and our interactions, but my God, I mean, your experience is an unbelievable one. It makes perfect sense why you've pursued this. My God.
Yeah, and it's also, right, I think it brings up this question of voice, right? And I would like to think, like you, right, when we're in, right, we think and I said we're the best case scenario, we're the ideal case scenario, right? In that we have knowledge, we kind of know how the system, right, works, and we know how to interact things, even to help people to be efficient, right? I know how to tell you a story where I'm not, I'm not taking a long time because I know, right, I can just, okay, I have chest pain, blah, 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 and it's not radiating, it's this, right, right. So, we know how to do that piece. So it's not in, what was interesting about that moment was, I'm talking to a colleague, we're expressing in the right clearest way that I can, and yet something was still missing, right? And I'm not saying just the colleague, it was the whole team. It's everybody that was taking care of me, right? It was, I remember, right, talking to some of the nurses, and one of the nurses, like I really, like I said, I really wanted to breastfeed. And so, they came in, and it was just like this. I said, okay, well, I really want to breastfeed, help me in doing this. Some of the nurses more equipped than others, right? Or send the lactation specialist in, or I would wait. I would want to say, well, okay, I know did bring some medicine in. For instance, they would bring pain medication in. I'll never forget this. And I have never had pain medication in my life until that moment, other than Tylenol and stuff, right? And I think the after the spinal wore off, they're scheduled to bring you different stuff. So they brought, I don't know what it was, Percocet in too. And so the first time I took it, and it was, I took it and I was like, oh my God. But I was like, I couldn't focus. I couldn't see. I couldn't hold the baby. I couldn't do anything. And then once it wore off and she came back the next time, she was like, here's, and I was like, oh, no. Like, I can't do both. I was like, is there any way I can just take one? Is there any way I can take just Motrin or some? She's like, this is what's ordered. And I was like, I get it, but I don't want, she's like, and her fear was, it was really interesting because her fear was, you need to take this now because I need you to be without pain because I have other things to do. And what I don't want is you have breakthrough pain and now you are bugging me because now we're chasing something that we could have just stayed on top of, right? I think in her mind. And then I would have been, right? I think that was and so it was better to just take it. And I'm like, but I said, I really don't want to. And she was like not happy with me. I was like, I'll take one. She's like, but I have to watch you take two. I was like, I'm not taking two. I'm going to take one. So, it's that type of stuff. And I was like, please bring me Motrin or or then I remember with my second child. So I had my second child 18 months later, my daughter. And because I was right back, the same thing happened, right? Right after delivery, my blood pressure started to go up. Now I'm in the hospital. And so I remember being still in the recovery room and I'm up and I'm clearly awake and stuff. And so the nurse comes in and she's bringing a bag of IV fluid. Right. And this is after the Pitocin thing, right? She was just bringing me another bag of IV fluid. And I was like, whoa. I was like, do I really need the IV fluid? I was like, I'm not nauseated. I can drink. I don't have any dietary restrictions. Like, did you? And she's like, yes, this is what the doctor ordered. I was like, I understand, but I'm just wondering, do I really need? I've already gotten did you see my chart from just 10 months ago when I was here? Like, I don't want, right? And it was just that constant thing. Now, it wasn't quite, it was just asking. Or, same thing with pain medication. That very visit too, she came in and they wanted to give me a shot of Toradol. And I was like, wow, do I need Toradol? Do I need morphine? Can I just get? And so then she was like, well, you'll have to talk to the doctor themselves. And I was like, okay, that's fine. Send them in. Right. So then the anesthesia team came in. They're just like, what's wrong with? And I was like, I'm just wondering, I feel good. I'm okay. Do I need to really have a shot of morphine or a shot of Toradol? Can I just get some Motrin or Tylenol, a gram of Tylenol? Can we just, right? So anyway, but it's right. And there's a really important study out there called Giving Voice to Mothers Study. And this study was a national survey that was done between 2016 and 2017. And it was a study that looked at the national experience of receiving maternal care in the United States. And he really wanted to examine how race, ethnicity, and the place of birth, right, interacted with how people were receiving maternal care. And it was really well done. They ensured representation from all the communities and had a really robust multidisciplinary team of community members, clinicians, researchers, community health, right, to make sure that they got a good representation for the study. And they had a sample of about 2,700 participants, of which 2,100, a little over 21, completed the survey. What was interesting about this piece, so 90% of these participants were US born, completed high school, were between 25 and 35 years of age. They were, racially distributed. And what we learned in this study was that participants reported experiencing one more type of mistreatment during the pregnancy or postnatal period. 1 in 6, 17%. And that when you looked at what did they report, about 9% said that they had been shouted at or scolded by a healthcare professional. That was the most common, and that differed based off of race. So Native Americans, Indigenous Americans, about 33% reported that, and 23% were African American, about 14% were white, and 25% were Hispanic. But 9% reported being scolded at or shouted by a healthcare professional. 8% said that they were ignored, refused a request, or the healthcare professional failed to respond to them. 6% said that their physical privacy had been violated. About 5% said that a healthcare worker threatened to withhold treatment or force them to accept treatment they did not want. And 80% said that they experienced mistreatment if their opinion differed from the healthcare professional. So, this helps to provide evidence that, we do a good job just kind of delivering our care, but are we really? It's in the nuances of these conversations, right? Like you said, the placing the hand, on someone, and
Placing the hand with permission.
Yes, right. Hence the 6% that said that they were violated.
Talking about that, Faisel, it reminds me of the discussion about the importance of building trust. It's very difficult to get good outcomes without a trust between the provider and the patient.
That's right. And especially for people who don't, Dr. Davis, you chose to go back to that. Why did you choose to go back to that same hospital?
That's where my doc was, right?
See, Dr. Davis, another perfect. How many times we've heard this, that people say, "Oh yeah, it's the practice, whatever," but I love the doctor. We love the doctors, and
it was my neighborhood. It was my hospital, right? It was where he was assigned, and so.
It makes me think about. So now, Dr. Davis, I'm no longer with ChenMed. I work at City Block Health, so mostly Medicaid space, and I'm medical director to help grow the Florida market for City Block, and just constantly, daily, with the population of people we're looking after the difficult to engage population. So the insurance company will, give us a group of people who historically have had difficulty with engagement. And what we hear on a daily basis is it's not like they're going to wherever they're going because it's the best place for the best care. There's no choice, right? They're going because that is the only place they can go. They don't have a choice. And so when we were both at ChenMed, we got to see firsthand where patients lived, like the zip code or the parish where they lived, the difference just where they lived compared to like in New Orleans was the most stark, unbelievable example. There's a parish where the life expectancy, this is just 7-8 years ago, was 54, 56. And then the zip code next to that, the life expectancy jumps up to 81, 82, just based on where you live. And now talking with you, it's, when we're talking about the hospital where you're going to give birth, especially for those who don't have a choice in it, how can we be sensitive as a healthcare delivery system? It's one thing when people are choosing to go where they want to go, my doctor is here, I live here, but there are many people who don't have a choice.
And you're right. I want to say that I think the answer to that is, and it will be challenging, but it's true. We need to focus as a hospital system, as a healthcare system, to think about the type of environments and hospitals that we want to create, right? And that these hospitals should foster, right, what I like to call a psychological safety first. And that's for everybody, right? A environment where anybody can question, exchange ideas, right? Disagree, have conversations, and not be made to feel unheard, right? Because one of the things I think we learned from the FAA, remember a long time ago, was a lot of near misses and crashes were happening because everybody that worked in the airline from the time you step through the right before the jetway, right? The teller, or what do you call it? The people, the flight attendants that take care of you on the outside versus when you got through the jetway and get on the plane, and the ground crew. Like when people saw stuff, they were hesitant to say something because of the pilot, right? And they created a process. They saw that in the FAA, they needed to create a environment that was going to allow people to say what they see, right? So if I'm a flight attendant and I see that, this procedure didn't happen, or the door didn't shut, or the pilot did, right, I need to be able to say something and not feel that I'm going to be, any kind of retaliation or anything's going to happen to me. But we're doing it all in the effort of being safe. Like we all have a responsibility in it. And it's the same thing with, right, in the medical situation. There's so many people that touch the patient, but I'm sure there are people that see things or hear things, but they're not going to question, the doctor that comes in the room or the nurse, or that, right? No one's going to speak up and say things. So I think we need to get back to creating a situation where, and I know in one of the hospitals that I worked at, we created a situation where in an effort to kind of create this type of environment, you were to ask, anyone could ask on the health professional team, I need more clarity, right? When they saw something, just that simple phrase, it was, even a medical student, if they saw something, to say, Dr. Something, I just need more clarity on why is this happening, or right. And it was to make a situation where everyone pauses for a moment, but not necessarily kind of, humiliate or right. But right. It's just to make everyone stop in the moment to say, what are we doing? Right. Like let's before we proceed, something is not right. Right. But we need to think about how we can create a situation where at the end of the day, people's voices matter. And we can create a situation where I'm actually encouraged and incentivized to speak up, as opposed to not speaking up. Same thing with medical students, right? Medical students see stuff all the time, but because they feel like they're, on some part of this hierarchy, that they won't say something. And I tell medical students all the time, if you see something, say something, because you often are the closest person who has spent a lot of time with a patient on the team. And so your perspective is important. Yes, you may not be the person on the team that has all of the experience and know, but you are the person on the team that does see and does observe and spends quite a bit of time with the patient and gets some levels of information sometimes that other team members don't have. And so being able to share that perspective is really profound. I'll give a quick example of this as an example for medical students. I remember when I was a medical student, and this has really stuck with me, and I keep recounting it and I hold on to it a lot, even where I am now. But I remember being a medical student, we were on rounds. It was a patient of mine who I had spent time, getting the long history and this. And so we're on rounds now. And I remember the attending was there and the resident was presenting, and out of his mouth was, this is a 60-year-old, Black male with hypertension who was non-compliant with his medications and was admitted with a stroke. And I was like, wow. I was like, and he went ahead and did the whole thing. And so I remember just adding, though, I said, well, let me just add that I had a chance to talk to Mr. So-and-so, and, he actually was taking his medications every day up until the last week because he needed to pay his rent. And he had money to pay his rent or money to pay his medications. And in his mind, because he felt good and he didn't feel bad and he wasn't having any symptoms, he said, well, let me go ahead and pay my rent. And then when I get paid, I will then get my medications. And it just so happened in that time frame, right, his blood pressure shot up and he is now here. Right. But because that mischaracterization of the patient as being non-compliant. He says, I keep low salt diet. He had done all the things. It just in that moment, money was tight and he had to make a decision. And so by sharing that, I was able to refocus on, number one, not mischaracterizing this gentleman who really did care about his health and made a decision I think a lot of us would make, right? Because hypertension doesn't hurt. You don't feel it most of the time. And so, and if you think, if I've been on my medications this whole time and it's been controlled and
now you're one of those people with a 200 over 100. That was you.
Right.
They said, don't breathe.
So, and I think sharing that helped, number one, refocus this man in everyone's mind, and also get him the care coordination and social work to come in and help work with him to get some medication vouchers or whatever it is that right? As opposed to just letting that resident's, presentation ride, right?
The stigma of speaking up, all the invisible stuff, like these, we do all these terrible things that lead to this deadly gaps, right? I mean, and then the how the patients respond, how timely, especially around the birth of a baby. I mean, I remember I told Dr. Dan this story. One of the first deaths I had was post-delivery. It was within 3 days. It was awful, god awful. Uncle herniation happened. She had headaches. She was trying to treat it herself at home with Tylenol, and she finally came when she couldn't take it anymore. And I remember I was an intern, and I remember the nurse saying, yeah, she's got a really bad headache. And no, she was just here a couple of days ago. She delivered a couple of days ago. And I just, we're student, you're an intern and you're seeing zebras for everything. And I ran to her, but it was already, her pupil was dilating, right? I'll never forget it. Never forget. And how quickly patients respond, but also us in the system. And that time, in that very delicate time where, those gaps, it's a matter of life and death.
And what you're bringing up and highlighting, for us to think about when we think about the things that contribute to maternal mortality, we know that 80% of pregnancy complications, right, especially in the postpartum period, are preventable, right? Like, that's the part that's heartbreaking. 80% is preventable. Like, this stuff doesn't need to happen. Right.
But how do, and it happens a lot of other places in healthcare. So right now, the vast majority of hospitals are getting paid to extract value out of the system, not getting paid to provide value to the patients. And it's much more, I don't know about Maryland, but in most of the other states, it's much more profitable to open NICU beds than it is to spend money to prevent premature deliveries by providing transportation, for patients to get to their prenatal care. I remember when I was doing OB back in the dark ages, it was July and it was just stinking hot, and there was a lady came in from West Virginia, I think, so, 100 miles away, and she was sort of had, delayed onset. And so we checked her a few times and she wasn't changing, and somebody said, well, you should go walking. And she said, well, where can I walk? And somebody said, oh, I don't know, you should probably go to the shopping mall, Fashion Square Mall, because it's cool, it's not so hot, that'd be a great place to walk. Nobody knew that she didn't have a car. So she came back in about 3 hours later. It was 100 degrees outside. She got about, it was probably 3 miles to the Fashion Square Mall. She got about 2 miles of the way she was doing what she was told. She was going to the mall to walk and went into labor on the side of the road, and somebody had to bring her back in. And so, we just think transportation is easy. We have a car, we drive to work. It's not a big deal. But for people that don't have that access, how do we, it's not terribly expensive. I mean, an Uber is not terribly expensive when you think about what we're dealing with, but we don't generally have a way to provide that care for people to get that care. So, I mean, that's not one of my, brighter moments from residency, but it certainly stuck in my head all these years later about being real careful what you're telling people to do, because they will sometimes literally do. I mean, a lot of times they don't do what we would ask them to do, but other times they literally do everything we do, and you can get in trouble with that too.
That's very true. I do want to say, I think on that note, though, Dr. Dan, and I think some positive things that we're seeing is so I think there are some steps to try to understand the social determinants of health. Now, as of last January, Medicare, or CMS, I should say, has required that we collect it. Right. That's the first step, that you have to at least show that you have assessed, the different areas of social determinants of health. So really, helping to ask about it, to document it. And, we also there are people trying to address things like transportation. So, contracting with Lyft and Uber to get patients to and from. There's also lots of focus on now, I think, with the cost of care being so high, how do we move care back out into the community, right? This now, I would say, rebranding a little bit of primary care, right, as population health, right? Because I would submit that we've always, as family physicians and primary care docs, been in the community in which we've served, right? Providing care where people spend most of their lives and where they really truthfully want to access it, right? Nobody wants to come into the big institutions and get care unless they have to, right? You want to just pop over to your local, your doc that's in the neighborhood. So I think it seems like this shifting now, where we are starting to think about how do we move care back into the community? How do we reimagine some of the spaces that can help provide that care and partner with us, right? So we think about our faith-based institutions, school-based care, mobile health care, right? All of these other structures and places that now can bring the care out into the community, and then certainly help to identify people and if they do need to come to a higher level of care. So, I think we have to wrestle with that now and really think about, how we continue to, even partner with nonprofit organizations. I think I shared, one of the things that we have been doing in the space of maternal health is partnering with Healthy Start. And Healthy Start is a community-based nonprofit that provides prenatal and postpartum support to women and children in underserved areas. And it's mostly to provide anything from community health workers, prenatal and postpartum doulas, health educators, nurses, lactation specialists, right? But we've been partnering with them because, they already are doing this. They already have a level of expertise. They already do what you said, have that trust with the community, because many of the people who work in these organizations are from the community. So they really have that trust, and they spend most of the time with patients where, we might only spend a little bit of time when they come in. They're there all the time. And so it's really reimagining partnerships with organizations like this to say, so we're doing a trial that looks at controlling blood pressure in a cohort that has hypertension disorder of pregnancy in a randomized controlled trial. And what we are partnering with them on is, can we train these doulas to become what we call, quote unquote, heart health doulas, right? Teaching them about how to support a patient around blood pressure control, diet, exercise, addressing all of the life essential 8 cardiovascular risk factors, right? To promote cardiovascular health in the mom, right? And so if we can train them, build their capacity to be able to do this, give this knowledge, do the blood pressure control, teach women how to be adherent, all of the things, then it's one of those things that even after the project's over, right, they now have this ability, this capacity now to continue to do, in addition to all of the wonderful things they do to support recovery after pregnancy, but now coupled with this knowledge and skill to really address the cardiovascular risk factors and look for, blood pressure and things after postpartum, and help connect these patients back to care more quickly. Maybe we can catch, some of this, these complications and stuff that can occur. So I think it's also working with these organizations that are already got an expertise, because they can be an extension. So I have been proposing, instead of the multidisciplinary team that we have on the internal healthcare side, right, that we expand that care team to include what I like to call community health professionals, right? Our doulas, our lactation, our community health workers, right? All these people who are helping in the spaces that we're not. And if we continue to help build their capacity and their ability to serve and then to connect back to care, and we have that communication, I think we can address a lot of these complications that we see.
My gosh, Dr. Davis, my goodness. Thank you so much for joining us today and having this conversation.
That's the highlight of my week, let me just say.
Same here. I mean, we're busy in our spaces and all. And I mean, obviously there's so much work that we need to do. But I do believe that it's conversations like this that help keep us moving forward. We're showing up for each other. We're showing up for our patients. I think, and then hearing your story, and actually, I think I love it when we as physicians share our own stories.
Yeah, because we're human too.
Nobody chooses to become a patient.
No. And it's scary, no matter, right? Even being a physician, it's still a scary moment, right? Being a patient, you're vulnerable. And I think, honestly, it's probably important for us to be patients from time to time, right? Because that ability to kind of see from the other side and be remembered and to see, oh my gosh, is this what patients are experiencing, right? I think you can't appreciate it unless you're on that side. And, I don't wish anything bad on anybody and don't want anyone to be in poor health. But I have to say, when I was in that situation, it really did help me to see and appreciate things very differently and understand, I think, also how to navigate, right? How to listen even better, right? And so I think those moments do help. For me, it helped me, I think, continue to become a better doctor. There's always room for improvement, right? But I do think, I will say, it is important in this space right now that we have all that we need to do to solve these problems. I really do believe that. We have tremendous, and these medical students, if I'm talking to the medical students, you have just get that training, because that training, the expertise, that skill, that is what's going to help make a difference. It doesn't matter what's going on in the world, honestly. It doesn't matter. You rely back on that skill to be able to care for patients. Listen, be in the moment, do what you can do, bring that talent to bear. That is what helps us to move forward. And care. Just to start with caring. Let's just start with care. Just care. Just listen. And let people know that they matter.
My gosh, Dr. Davis, thank you again. This was a great conversation. What are your thoughts on connecting back to care, reimagining maternal health? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.